Close to the bladder neck is where the prostate is. And in that area, there's a valve that prevents ejaculatory fluid and semen from going up into the bladder. So whenever somebody undergoes a transurethral resection of the prostate, a TURP, one of the most common complications from that is retrograde ejaculation. Ejaculatory fluid going back up into the bladder. All patients that were undergoing TURP need to know about this. In a pregnant woman in the 2nd to 3rd trimesters, there is a phenomenon of round ligament pain, which has pain that is near the inguinal region and groin. However, there's also another etiology that you need to look out for that has pain in the same area. Okay, and this is going to be nephrolithiasis, a kidney stone that is in the pregnant patient. Okay, don't confuse these two. One of the biggest things is really the severity of pain. Okay, the severity of pain for round ligament syndrome is going to be mild, whereas the pain for nephrolithiasis is going to be severe, and then it's going to have the time frame of being paroxysmal. So it just comes suddenly and then leaves, and usually is associated with nausea and vomiting as well. So when you have a patient that comes in with this kind of symptomatology, you want to rule out the kidney stone, okay? And the way you diagnose this, the first thing that you're going to do, because the patient is pregnant, you're not going to give them a CT scan right away. What you're going to do is a ultrasound. You're going to do a renal ultrasound and a pelvic ultrasound, okay? Once you do this, you may not directly visualize the stone, but you may see hydronephrosis and or hydroureter. And that tells you that there may be a ureteral obstruction due to the stone. If you need further data to try to prove that this is the fact, then the second thing you can do is a transvaginal ultrasound. And this is going to specifically look for stones in the distal ureter. If you need even more radiology to try to definitively prove this, you can do an MRI or an MR urogram. You can also do a low dose non-contrast CT. You have a newborn and everything is checking out normal. You do a heel prick and you see that the hematocrit is 70%. So if you have a newborn that has a hematocrit above 65% or a hemoglobin above 22 grams per deciliter, this is categorized as neonatal polycythemia. The one thing that you may be able to see is a ruddy complexion and generalized erythema on the baby. If this happens, it's not really a big deal. It's actually quite common to happen, and is usually observed within the first 2 to 3 hours of life and usually resolves within the first 24 hours of life. However, there are some complications that can occur from it if it's pretty severe, such as hypoglycemia, hyperbilirubinemia, hyperviscosity, hypoperfusion due to that viscosity, and tissue hypoxia for the same reason. And what do you do in this situation? One thing you can do is actually you can recheck the hematocrit or hemoglobin, but this time you don't do it from a heel prick. You do it from peripheral blood, and you may get a different value when you do that, because what happens is that the heel prick, the capillary sample that you're getting from the heel prick, sometimes can be inaccurate or unreliable. So what do you do in that situation? Just recheck it with peripheral blood. Now, what if this neonate with polycythemia is one of the rare few that develops significant complications or symptoms from it? Okay, how is that going to look? They're going to be lethargic, irritable, drowsy, poor feeding, abdominal distension, hypotonic, and they could have metabolic derangements such as hypoglycemia and hyperbilirubinemia. If you see this, the first thing you need to do is you need to expand the blood volume to decrease the hyperviscosity and decrease the hematocrit. So you do that with hydration. And since it's very common for them to have hypoglycemia, you correct the hypoglycemia, right? So ideally, you're going to give them some saline with glucose in there. Then the next thing you can do to start to correct this is known as a partial exchange transfusion, basically infusing normal saline while withdrawing blood. Okay, so you withdraw blood and you replace it with normal saline. Now, there are some risks associated with it, so it's not the first line thing to do. The first line thing to do is what I said before: hydrate and correct any metabolic derangements such as hypoglycemia. But if you're still having problems, then you can move on to do partial exchange transfusion. Vertigo can be caused by several different things, and narrowing down exactly what is the cause to this is really dependent on the time frame and triggers to the episodes of vertigo. Okay, so we'll go through all of these things. So we have Meniere disease, BPPV, which is benign paroxysmal positional vertigo. We also have vestibular neuritis. We also have migraine, which can cause vertigo or be associated with vertigo. And we also have, actual structural things in the brain, such as a tumor or a stroke. Okay. Now, let's go through how each one of these things present. Meniere disease. Okay. Meniere disease is caused by an accumulation of fluid inside the semicircular canals. All right. This is also known as endolymphatic hydrops. Okay. The fluid I'm talking about is the endolymph. And so this is the way it presents is episodes that can last anywhere from 20 minutes to several hours. Okay. And they're recurrent episodes, 20 minutes to several hours long. And they're also associated with hearing loss and tinnitus. Okay. Because this is caused by an accumulation of fluid in the semicircular canals, you treat this with diuretics such as hydrochlorothiazide. All right. Next one is BPPV, benign paroxysmal positional vertigo. Okay. This one is triggered specifically by head movement. Okay. So this can be a history of somebody saying, oh, whenever I get up from bed, or whenever I do a sudden movement, if they're like in a occupation, let's say, that needs their head to move constantly from side to side, it gets triggered when that happens. And these episodes are brief. They can happen for less than a minute to about a minute long. All right. One way that you can diagnose BPPV is by doing the Dix-Hallpike maneuver, which causes nystagmus. The nystagmus is a positive sign for this. The way you treat this is by doing an Epley maneuver, which is known as a canalith repositioning maneuver. The thing that is thought to trigger this are these little rocks, okay, or crystalline debris, canalithiasis, all right, canaliths in the semicircular canal, okay, not fluid, but stones in the semicircular canal. So you want to reposition the stones by doing these canalith repositioning maneuvers. An example of that is the Epley maneuver. Next one is vestibular neuritis. Neuritis, there's inflammation happening. This usually follows a viral syndrome. It is an acute episode, acute single episode. The thing is that this is not short. It can last for several days. Okay, it can last for several days. And the way you're going to treat this, well, the way you treat most inflammatory conditions, with corticosteroids such as oral prednisone. Okay. Next one, or the next two, which I'm going to group together, are going to be migraine and any other brainstem or cerebellar stroke kind of situations. So migraine is going to be vertigo associated with, obviously, migraine. May have some auras associated with that. And in between the episodes of migraine, there is no vertigo whatsoever. Okay. And the brainstem or cerebellar stroke, this is sudden onset. And since it's a stroke, you will usually have other neurologic symptoms that accompany it. Okay. And for that, you're going to do imaging. All right, MRI of the scan, or CT, or MRI of the brain, or CT scan of the brain. Okay, let's say you have somebody who comes in and they have an abscess near the anus or rectum. So we're going to call this an anal rectal abscess. Okay, so this is providing a broad anatomic location, anus or rectum. Okay, if you have the abscess near the anus, this is known as a perianal abscess. If you have it near the rectum, it's known as a perirectal abscess. And both of them are treated differently, okay? A perianal abscess is going to be located distal to the anal sphincters, okay? Distal to the anal sphincters, which means it's going to be superficial. You are going to be able to see it, all right? You're going to see the fluctuance and or the erythema and the swollenness of this abscess, okay? And you can incise that and drain it at the bedside, no problem, okay? Now, the other group, perirectal abscess, is going to be deeper than that, okay? And there are three main locations where you can have a perirectal abscess. These are not going to be obvious upon first inspection. You may have to do a digital rectal examination in order to palpate this abscess. So you can have an abscess that is intersphincteric, which means literally inside, at the level of the sphincter, whether internal or external, at the level of the sphincter and within the musculature wall of that sphincter. You can also have an ischiorectal abscess, which is not going to be inside the wall of the sphincter. It's going to be adjacent to that, okay, but deep enough that you may not be able to visualize it directly. The next one, and the deepest one of all, is going to be a supralevator abscess. So this is going to be an abscess that is proximal to or deep to the levator ani muscle, which is what makes up the pelvic floor. Okay, so that's going to be right up against the rectum, deep in there. All right. Now, how do you treat these perirectal abscesses? There's usually going to be systemic signs of infection such as fever and tachycardia, so you definitely want to give intravenous antibiotics. But in addition to that, this is not something that you can incise and drain at the bedside. You have to bring this to the OR to do surgical drainage, okay? But before you do any of that, you want to obviously know exactly where that abscess is, where that perirectal abscess is, so that you can know, so that the surgeons can know where they're going, right? So you're going to do a CT scan of the pelvis with IV contrast. Once you do that, you know what's going on. You start to intravenous antibiotics. You may do that at the same time or before you do the CT scan. And then the definitive treatment is going to be the surgical drainage in the operating room. One of the most common complications that can occur from a peri, or actually an anal rectal abscess, from whether it's near the anus or the rectum, is going to be a fistula forming. The fistula goes from the abscess location to the overlying skin. The most common cause of postpartum fever is postpartum endometritis. There's going to be a fever greater than 24 hours postpartum and uterine fundal tenderness. This is a polymicrobial infection of the uterine decidua. You want to give broad spectrum intravenous antibiotics, specifically clindamycin plus gentamicin. The clindamycin is going to cover aerobic gram-positive cocci and penicillin-resistant anaerobes. The gentamicin is going to cover gram-negatives and some gram-positives. You continue doing this until the patient is afebrile for 24 hours. The biggest risk factors for postpartum endometritis are cesarean delivery, intraamniotic infection, group B streptococcus colonization, prolonged rupture of membranes, or operative vaginal delivery. Essentially, anything that introduces or has the potential to introduce bacteria into the uterus. The most risky combo that you can have is a prolonged rupture of membranes, extended delivery for a few hours, and then followed by cesarean delivery. Those three things all together, forget about it. Very high risk. ALS, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, is loss of function of both upper and lower motor neurons. However, when it first presents, it may be just the upper or just the lower motor neurons that are affected. Let's look at what the clinical presentation looks for each. Lower motor neuron involvement is going to present with asymmetric weakness, usually in the distal limbs, okay? And the patient may also talk about cramping, which occurs in the early morning hours, and weakness. And the weakness that you have is associated with wasting atrophy of the muscles, and you can also have fasciculations as well. If you have inclusion of bulbar muscles, then you're going to have difficulty chewing and swallowing, along with fasciculations of the face and or tongue. Now, the upper motor neuron is going to look like hyperactivity of stretch reflexes, okay? Hyperactive reflexes. And you may also have spastic resistance to passive movements of the affected limbs. The current medication of choice for ALS is riluzole, which is a glutamate inhibitor. It will prolong survival, and it may prolong survival and delay the need for a tracheostomy. How to identify a child that may have cerebral palsy. One of the main things is delayed motor milestones, right? That's one of the first things that starts to clue us in. And let's look at some milestones. Like, for example, by the time a child is 9 months old, they should be able to pull themselves up and cruise. So basically they could stand or they can walk by holding themselves onto something. They should definitely be able to roll from belly to back or back to belly and sit up without any support. If you've reached 9 months and you haven't seen any of these things so far, then there's definitely delayed motor milestones. Then we talk about some neurological things that you can see, or some musculoskeletal things. Hypertonia, spasticity. Contractures, which sometimes can present as scissoring of the legs. Sustained clonus, hyperreflexia, all these things, okay? Asymmetric fisting, early hand preference before the age of 1, persistent neonatal reflexes such as the tonic neck reflex, okay? All these things can tell us that cerebral palsy may be in this child. What are risk factors that can clue us in as well? Prematurity, low birth weight, intrauterine infection, or perinatal asphyxia. How can you diagnose this? It's clinical, but the definitive diagnosis is done by brain MRI, where you can find periventricular leukomalacia, basal ganglia lesions, and some evidence of anoxia to brain tissue. Treatment, pretty much supportive with therapy, occupational therapy, to help the patient learn how to do what they can do. Tick paralysis. It most commonly happens in Australia or Western North America. There are about 40 species that can cause tick paralysis, but most of the cases are due to 2 different species, one of which is Dermacenter andersoni, which is known as the Rocky Mountain wood tick, and the other one is D. variabilis, which is the American dog tick. And this usually happens when somebody gets a tick bite, or a tick attached to them, I should say, and is not quickly recognized, because the neurotoxins in the tick saliva are transmitted over 4 to 7 days. So if the person initially realized a tick attachment and got rid of it on the same day, then the likelihood of them developing tick paralysis is very low. But if they don't realize that it's there and it's been stuck to them for 4 to 7 days, then they're going to develop tick paralysis. This is going to start with a prodrome of fatigue and paresthesias, is then going to develop into gait ataxia and ascending paralysis that can develop within hours, and then absent tendon reflexes. Okay, this whole thing starts in about 2 to 3 days after that initial 4 to 7 day attachment of the tick, right? usually associated with camping and hiking, obviously. And what are you going to do? Well, first thing you want to do is look for the tick, see if they have the tick on them, and then you go from there. The go from there, surprisingly, is not that complicated. Just remove the tick, all right, in the typical ways that it is advised. Don't squeeze on it. Try to remove it as close to the skin as possible. You don't need any treatment after that. Usually, once you remove the tick, most patients recover completely without any other intervention. This is not like Lyme disease.